live. There's a little bit of a delay, and I think we're going to be live in a second. You'll just tell me so we can see. Oh, we're live. I'm so excited when the technology works. It's like unbelievable. It never happens to me. So everybody, my friends, hello, my friends. I'm so excited for you to meet one of my very special friends, Dr. David Wohlsifer. We did our PhD together in the craziest, most interesting place in the world, the Institute for Advanced Study of Human Sexuality, right? Was that a crazy time? How many years ago was that?
103.
Yes.
No, it was 2004 to 2006.
It's crazy. That was really those 15 years ago? God,
yeah, more.
No, 2000 and
I got my PhD in 2006, so we started around 3 or 4.
Yeah, you did your PhD faster than anybody I know. I think at your graduation they said, there goes your dog and there goes your partner. Hello, guys. And I think at your graduation they said that was the fastest PhD anybody did. Okay, you got to introduce us to your dogs, David.
Oh, okay. We're live on Facebook, Jeff. Jeff's concerned. We're totally live. This is Bella, Chloe, and my husband, Jeff. Jeff, we're live.
Jeff, we're live. Get lost, right?
You can sit down and join us.
Yeah, absolutely.
He's trying to figure out how to get on.
Oh, if you follow Dr. Sheva, it should say she's going live. Just follow the page. It should be right there.
I just put share video with friends, Jeff, and so that should work.
Okay. So this is Dr. David Wohlsifer. David is a co-owner of the Center for Psychotherapy in Boca Raton, Florida, which has much better weather than we do in New York. So it was a very smart move on his part. He is also a full-time faculty at the Florida Atlantic University Sandler School of Social Work. And he teaches cognitive behavioral therapy, which is what we're here to talk about tonight. So David, why don't you just jump right in? Tell people what is cognitive behavioral therapy?
Cognitive behavioral therapy started, in my opinion, with Aaron Beck at the University of Pennsylvania. And the basic premise of CBT is that how you think affects how you feel and what you do. That's the simplest way I'll start CBT. Now it goes a lot deeper.
So how you think affects how you feel, therefore what you do.
Yep. And in tandem.
Great.
Hence the cognitive and cognitive therapy. Now it goes a lot deeper. As you get deeper, you get into core beliefs, schemas, conditional beliefs, compensatory strategies that really start in early childhood, like most forms of psychotherapy.
So what does that mean practically? And then tell us like what's different. Like somebody comes into you and sees you rather than, sort of a classic psychotherapist, which is amazing. I'm not putting down classic psychotherapy. I just give people a sort of a snapshot view of what's different about cognitive behavioral therapy.
Cognitive therapy is problem-directed and solution-focused. It's aimed at getting to the heart of the problem that the patient presents with. Where you start isn't always where you land, but it's about really getting into the underlying cognitions that are causing behaviors and emotional changes in your patient.
So can you give us an example?
I'll give you a great example. Do you want a sex therapy example?
Sure.
Okay, so let's say I'm a person suffering from erectile dysfunction for no medical reason whatsoever. And I come to the cognitive therapist, and the first question any cognitive therapist is going to ask you is, what's going through your mind right now? And let's say I interview the man who's saying, or the male identified person who's saying, I have erectile difficulty. And I say, what's going through your mind right now? And he describes his partner, and he says something to the effect of, I think I'm going to fail at this, or I'm not good at this, or this is going to hurt me, or this is going to hurt them. And instantly that'll cause a change in our bodies and an affective change in our emotions. The cognitive therapist wants to get into the cognition that's causing the change in the emotion and what the body's seeing. As you work together, you're going to go deeper into the core belief level about how that person sees themselves in the world. I think of core beliefs as sort of a well that all our thoughts come from. So, am I making sense?
Yes. So basically, let me try to translate this even further. So where a traditional therapist may say, let's look at your family history and your family background. They may start with that and sort of say, I want to get your family history and your family background because I want to see if you have some trauma or some problem in your past that's making you feel this way. You're more saying like, what is going on in your thinking process right now? Is that
exactly?
Is that a fair way?
Exactly. But it's interesting because I'm even listening to you say traditional therapist. And remember, Dr. Beck, who is 99 and still practicing, was originally an analyst. And so we're not exactly as cognitive therapists that far are not traditional, because we also look at family of origin and how that impacts how you're thinking.
Right.
I mean, how can your family of origin not impact how you're thinking now?
Right. But you're starting, I think it feels like you're starting.
You're starting in the here and now.
Exactly.
You know, I was originally trained psychodynamically, psychoanalytically, where I started in the past.
Right. But now you're starting with the now.
You're
And
starting
then,
in the here and now.
and then when you feel like somebody has not weird, that's a better word. If you feel like somebody has just distorted thinking that's impacting on
How about
their
challenging cognitions?
Okay, challenging cognitions. I'm
Or
trying
dysfunctional thoughts. I'll be real
yes,
cognitive.
dysfunctional thoughts. I'm trying to find language that,
I'll do it for you. Dysfunctional thoughts.
Okay, somebody has dysfunctional thoughts.
Mm-hmm.
How do you change that?
I think the first step is identifying them. I mean, I often joke about my day and how I go about thinking. And my thinking can range from anywhere from, I'll be driving and I'll think, I really got to get to work. I wonder if there's a God. I like turkey. Turkey's better on rye. Maybe there's life after death. And within nanoseconds, I'm going in all those places. And most of my thoughts are relatively mindless. And often we have to first get the affective response, the feeling response, to be able to hone into the cognition that's creating what we're feeling and what we're doing.
So do you
Am I making sense to you, or?
Totally. So do you tone into the, right, but I'm laughing a little because you make sense to me. I want to make sure you make sense to somebody who doesn't know cognitive behavioral therapy at all.
So I'm taking a look.
Yes.
I see a lot of my former students watching. Hello, all of you. So
hello.
I hope I'm making sense. Guys, tell me in the chat box if I'm making sense.
Otherwise, but what I think you're also describing is that sometimes when you have thoughts, you don't even know you're having them. So that's what you just said.
Have you not had that experience where you're in the moment, you yell at your husband and you don't even realize why you did?
Totally. All day long, I am having those thoughts. and then you're connecting them to a somatic experience?
Could be somatic, could be affective, feeling, could be behavioral.
Okay, so like, can you break that down a little bit?
So sure, let me think of an example. My original part, what got me into sexology was running a clinic at the Center for Cognitive Therapy at the University of Penn for sexual abuse survivors and ritual torture survivors. And I treated at that time, it was
people may not know. People know it sexual abuse survivors, but ritual torture survivors, you have to define.
Satanic cult survivors, people who survived hostage situations, refugee situations, kidnappings.
How many people did you have from those situations?
You're busy. I mean, most of them were sexual abuse survivors, but I actually treated a lot of satanic cult survivors. There were people who were harmed. Harmed in different situations. Well, there's people who are in.
No, I hear that, but is that a lot?
And I also, what a big part of the population too was? A lot of people from South America who had gone through kidnappings.
Wow.
Yeah, so there was a whole bunch.
That's a specialized area of psychotherapy. I
will tell you that the majority of the people we saw were sexual abuse survivors.
Yeah, that wouldn't surprise me. That doesn't surprise me at all. The other one was super.
And they're not, let's be honest, they're also not mutually exclusive. In the course of all kinds of traumas, people often experience sexual abuse.
Yeah, no, for sure.
So if I think about what happened, a lot of the people I worked with, one of the things we were working on was helping them to be healthy and sexual again after a trauma. How do I reacquaint with my body having been traumatized?
So I got you a little sidetracked because what you were talking about is you were going to give me examples of when they have these thoughts and they don't know they have them, but they identify them, and then they have either somatic response or a.
So let me give you a case example.
Perfect.
And I'm going to alter it a little bit. Somebody came to see me for what we used to call vaginismus, which we'll now call dyspareunia. And she was having a vaginismus and she couldn't, I'll let you explain vaginismus. I'm sure you could do it better than me.
Yes, vaginismus is a condition where you cannot get a penis into the vagina. In some cases, it's so severe you cannot get a finger into the vagina or anything, a tampon in the vagina. Or it can be not so severe where you can do it and it's painful. It is very often connected to very tight muscles and your brain's fear.
It's psychogenic. It's psychogenic, yeah. So I'm making this up for confidentiality's sake a bit. So this young woman and I started working together, and she could not understand why she was having vaginismus. Gynecologist saw her. It was medically ruled out. No medical reason. It was clearly psychogenic cause, mental health-wise. And we worked and we worked and we worked, and she could not figure it out. And then one day she was simply cleaning out her bathroom, and she came across a bottle of Old Spice that somebody had given her husband for Christmas. And instantly she knew, she had the cognition, that's what was doing it. He had been given the Old Spice, he had started wearing it, he didn't tell her. She had a sexual abuse as a child, and the perpetrator were Old Spice. Once she got in touch with the smell, she was able to say to herself, my thought is, this is dangerous. And it was causing the vaginismus. So see, the cognition causes her body to go into defense mode. The smell was the trigger.
So that's a great example. So now my question to you is, how do you get somebody to be able to identify, like what happens to her that she's able to be in the bathroom and identify that?
This is an extreme case. An odd situation, I guess you'd say, where a smell triggered. It's not really odd. Smells do trigger a lot of people. I shouldn't say that.
I'm a big person. Like I feel like when I go someplace where there was a bad smell before, I feel like right.
And things trigger us smell-wise. I think most people, when you work with them, you try to invoke a scenario where they're able to get in touch with what they were thinking. This is the cognitive and cognitive. What were you thinking when you were experiencing whatever it might be?
So a patient comes in and they say to you, you know, I don't know why, but I'm petrified of heights. I'm just right. So what do you do with them?
The first thing I would ask them is, I would invoke a scenario. Let's go up, or let's think about going up, and tell me what the automatic thoughts are in your mind.
Right.
What's going through your mind right now? Go ahead.
Right. No, that is what I think is so fascinating about CBT therapy, right? Like, let's create the scenario either in reality or in your head, and then let's sort of act on it together to figure out what is going through your head. And then do people have a really hard time doing that?
Yeah, well, it depends. Some people, look, let's say you're afraid of heights, and I want to bring you into a scenario like that, where I'm going to ask you about your heights. I'm going to make you think about heights. I may even ask you for homework. Cognitive therapy always has homework. We say to our patients, you're with us 1 hour a week, 2 hours a week. Practice on your own, where I'm going to give them homework to go someplace high where you invoke enough of an affect to lead to a cognition. So you're afraid of heights. I'm going to say to you, why don't we go, you have a friend, she lives on the 15th floor, go to her apartment this week and look out her window. Write down your automatic thought. What do you feel? What do you do? If you can handle that, go to her balcony. What do you feel? What do you do? What are you thinking? So as you start to solicit the thoughts, and I think the more we become aware of our cognitions, the more we start to notice them. The more we start to tap into them, the more we start to notice them. And the same thing goes on sexually, if you want to bring it to sex therapy.
Right, right. So what are things you would say that you think CBT is kind of the most effective with? And then we'll move into the sex. But like if somebody's coming to you, or do you feel like it's equally successful with almost every kind of cycle? Like if you were talking to somebody and you were saying, okay, for these things, I really would recommend CBT as opposed to IFS or something else. Do you know what I'm saying? Like, what would those things
be? I like to integrate a model. I was trained both in psychodynamic, family systems, and CBT. And I always think like a cognitive therapist, and that I always do a case conceptualization, the full case cognitive conceptualization in my mind and in my chart, be it family, couple, no matter what the issue. I really don't like to privilege one school of therapy over the other, because I think it's what works for the individual therapist. In my graduate program, a supervisor once said to me, you think cognitively. And I realized she was right. So it works for me. So I don't really want to privilege one over the other. I know what works for me.
You don't feel like there's certain problems that would be more effectively treated? Like, for example,
Well, I obviously have a bias because I chose to be a cognitive therapist.
So do your bias. Like, you're not going to.
So my bias is that we're always thinking wherever we go. We're always thinking. Human brains are always thinking. And if we're always thinking, there's something being created into our actions and our feelings with what we're thinking. So I think, especially when people are working in places where they may not have a lot of time to work with their patients. Like, I'm in a private practice, I have a lot of time. It can literally be years with me. But especially for some clinicians who are working in places with brief models, it's something you can give somebody very quickly.
Right. So I feel
people are always thinking.
Right. I feel like that's one of the beauties of CBT is that it doesn't necessarily have to be something that you have to delve into and spend years doing it. That sort of makes sense. I also feel like, and you can correct me if I'm wrong, because this is where I go in. I feel like for anxiety, it's incredibly helpful. For depression, maybe a little bit less so.
I think the original CBT studies were based on Dr. Brecht's treatment of depression.
Really?
Look, you have depression-agenic cognitions. And I don't
Right.
want to underestimate the roles that medication can have. I
Right.
think you always need a family component in every case. I think you
Right.
always need to look at family system. You know, as I've evolved as a clinician, this is year 26. I think
Nah, you're only 30. How could that be?
I was 50 3 weeks ago, so this is year 26.
Happy birthday, David.
Thank you. Thank you. So, and now I'm a grandfather, so it's
Really?
where I
How
am.
old are your grandchildren?
One will be a year in October and one is 7 months.
Oh my God, that's amazing.
So,
What kind of thoughts did that bring up with you when you became a grandfather? Because I can tell you that was really challenging for me when I became a grandmother.
well, because I got my children when I met my husband later in life, and they're my stepchildren, and they've been brought into my life in a certain way. The first thing I kind of thought to myself is, wow, how unsexy. I'm a grandparent. I mean, I got to be honest. They call me Zaidi. My name is Zaidi, you know, the Yiddish for grandfather. And I don't really think of myself as a Zaidi, but at another level, I was tremendously honored because as a gay man, I never thought that was a title I'd have. And I feel very honored,
Bless.
you know, that
Yeah.
the children my husband brought to our marriage have
That
brought me
is
in that way. So it's
amazing.
been a journey that I never expected and absolutely loved.
You know, it's funny because when I became a grandmother, I know we're going a little sidetrack, but when I became a grandmother, everybody was like, you know, Mazel Tov, Grandma, Mazel Tov, you know, and I had such conflicting feelings about it. And I remember being so appreciative of somebody who said to me, congratulations, what's that like for you? Like this, not assuming you must be the happiest thing, this is the best thing in the world, you're so excited. I mean, I love my grandchildren beyond words. It took me a little while to get there, but it was
I saw your post recently.
I was a little conflicted, and I was so appreciative of people who were able to like congratulate me, but also make space for conflicted feelings. So
I think we froze.
The heading of thinking about things.
Well, I will share that I was absolutely elated. I've been waiting for it for years. Whereas I saw your Facebook post, I am a baby person. I do like babies.
Oh, wow. So were these like the first babies in your first babies in your life?
No. I grew up with, you know, nieces and nephews and.
Right, but recently, right? Because
recently. No, because my niece and nephew both have young children. I have a niece and nephew only a few years younger than me.
I could so see you being a baby person, by the way.
Yeah.
So calm. You're lovely. Like my husband's a baby whisperer. Like he holds a baby and they fall asleep. I pick up a baby, they start to scream.
So I had nieces and nephews who were having kids, and so, but you know, to cognitions, you know, you even bring up, what do we think? If you bring it back to what we're working on, what are people's cognitions as they age sexually?
Right. So now let's talk about why would somebody pick to do CBT for sexual issues, would you say?
Solutions. Look, what's the most sexual part of your body is your mind.
Right.
I remember a woman was doing couples therapy, and a woman said to her partner in my office, if you really want to make love to me, you need to start with my mind. And I thought that was the most sensual thing I had ever heard. It was the most sensual thing I had ever heard. And I thought it was beautiful. And I think it's true.
Right.
That people, when they begin to connect sexually or even with themselves, is a cognitive experience.
So talk to me a little bit about how you do CBT with couples. Because honestly, this is something I've never really thought about. Cool. And after raising it, I'm thinking, that's so interesting. I never thought of CBT as a model for couples.
Sure, because if you take the case conceptualization, which is the CBT diagram by which you get somebody's thoughts and feelings and emotions and core beliefs and childhood data, and you're putting together two partners, what you're putting together is two case conceptualizations.
Do you actually map this stuff out?
I totally map it out. And I guarantee if any students, I totally map it out. I use the case conceptualization every time, and I give it to my clients so they can see.
Oh my God.
You've worked with me. You know what I do.
No, you are. You're a little OCD. Can we just be honest here? You're a little like very OCD. So wait, so you do a map for every client?
I do the case conceptualization, and I keep it ongoing. It's in the left of my chart so that I always have an ongoing, I'll use your words, map of my conceptualization cognitively of the patient in front of me. So when you have two partners, you've got two together, so you can see how they overlap.
So make up a couple, you know, Dick and Jane.
That's so funny.
Sorry.
Look, I'll go back to the classic Woody Allen.
Yes.
Remember the Woody Allen? So there was the therapist seeing the couple, and the husband he says to the husband, how often do you have sex? He says, hardly ever, like twice a week. He says to the wife, how often do you have sex? She says, all the time, like twice a week. So you've got two automatic thoughts. He says, hardly ever. She says, all the time. That create two different emotions. He feels deprived. Maybe she feels overwhelmed. that causes them to act a certain way. And I think when you give couples insights, often couples, I think, are projecting back and forth onto each other what the other one's thinking. You know my friend Mona Fishbane. I absolutely love her and Michelle Shakeman's article about the vulnerability cycle.
Talk about it. I don't know what it
They
is.
talk brilliantly in this article. It's Shakeman and Fishbane, I want to say 2004. They talk brilliantly about how couples use their survival strategies when they feel their vulnerabilities hit. So I feel my vulnerabilities and I respond to my partner with my survival strategies that trigger his vulnerabilities, and he comes at me with my survival strategies. And I think things like that happen cognitively.
So you need to explain that better, because I don't think people listening necessarily know what vulnerabilities they may know, but survival.
So let me slow it down. When the places hit one partner that hurts, when you hit somebody in the places that hurt, they come out fighting with their survival strategies, which often trigger the hurt in the other partner. And like tennis, they're playing back and forth.
Right.
What CBT can do is slow down that process by helping people to mentalize, to get a sense of what the other person's thinking so that they can connect better. If I can understand what you're thinking, if I can truly understand what you're thinking, then I can have empathy for you. And if I can have empathy for you, I think I'll love you a little more.
Right. And I think sometimes we make the assumption that we know what the other person is thinking.
One of the biggest mistakes I see with couples, and I see this really badly in same-sex couples.
Really?
And that is, let me tell you what it is, seeing the other person as your clone. Especially when people are of the same gender. But I see it with heterosexual couples too, assuming because I do X, you must want to do X.
Give us an example.
So let's say I'm very confident in the workspace and I'm really happy to go running out there, you know, front line and center. I assume that since you're my partner, you must feel the same way and you must have absolutely no anxieties about this issue at all. I assume that punctuality is a priority to me. And that for you, it's not so much of a priority, that you must be wrong because you don't agree with me.
Right.
Am I making sense?
Yeah, totally. Totally. I am still fascinated by a couple piece of this, because I feel like I totally get, so you're breaking down what's the person thinking, but you've got to get people sort of breaking things down so that they're thinking at the same time as the other person is. To a certain degree.
I won't say thinking at the same time. Let's just slow it down, that they're respectful of their partner's cognitions. And even more so, respectful of the places that they came from.
You know, it's so interesting because I think one of the issues I often see, which I think really touches on this, and I never actually thought about it in this context, is when women have low desire, right? And their husbands are like, they're not having sex and the husband's really frustrated. So one of the biggest issues that come up, and this is often women and men, it can be the other way, but one of the issues comes up is that the women often pull back physically altogether, right? They're afraid that if they kiss their husband or touch their husband or stroke their husband's going to want to have sex with them.
Absolutely. I see it all the time.
Which is a legitimate concern, because the husband's understanding the kissing and stroking and touching as, oh, she's open to the idea of having sex. When really what's happening is she is just saying, I want to kiss you or touch you, or and I don't. So what happens is she pulls back entirely, right? Because if she makes any positive, motion of lovingness, he comes on and wanting to have sex. She pulls back entirely. Now he feels that double whammy. The men have a double whammy, which is not only am I not having sex, but I have a wife who is completely not touching me or making me feel loved, right? So their thinking process.
So they're both hitting into their vulnerabilities, so they come out with their survival strategies.
So that is right, exactly. So she is feeling vulnerable, so her survival strategy is to pull back entirely, right? And he's feeling
which hits his vulnerability.
Right. So then he gets angry.
Which is his survival strategy, which makes her pull even further.
Correct. And so that is sort of a classic, I think, example of where
it's a classic couples dance.
Right.
Now you bring up another thing, and I see this a lot in heterosexual men, and that is to ask for sex, because I think enough men, in particular heterosexual men, don't know how to ask for non-sexual touch. I think it's often seen as unmasculine for a man to say to a woman, I want you to hold me, I just want to feel close to you. And I think men have to work really hard at evolving to that.
What do you think the thought process is that's making men?
Well, let's make it cognitive. What are the core beliefs society puts on men about sex? And is it masculine for, I'm going to put it to the straight community, for a straight man to say to a woman, I just need you to hold me. I just need to feel close to you. But it's very masculine affirming to just ask for sex from a woman. And I find a lot of men want more of a gamut. We're getting questions. get more of a gamut of,
Are you seeing the questions? I'm not.
yeah, because I have it open. Susan Marks has a question for us.
Okay.
And my
Susan,
friend,
what's
my
the
former
question?
supervisor, Jackie, says I'm making sense. Thank you, Jackie.
Oh, good. You are making sense.
So,
Making sense. Yes.
well, I worry, so I think men need more room. And I think often
Your cognition is, I may not be making sense.
my cognition is so I feel anxiety, so I over-explain myself. So Susan Marks asked, how does the CBT model work with NT-ASD couples? All right, I'm doing a lecture literally Thursday on ASD and transgender, gender nonconforming, where there is no empathy from the husband on the spectrum. I really appreciate your question. And I think one of the things that you have to do with CBT is sometimes a lot of neuroeducation.
Yeah,
and I think
you need to explain that to the layperson.
so if say there's a husband and a wife, let's say, or two partners or a husband, I really want to hit her question, Susan's question. I don't know their pronouns, so I wanted to use neutral. And neuroeducation, we all have different neurobiologies, different neuro organizations. So somebody who's on the autistic spectrum may present as not feeling empathy, or that might be a skill that they're challenged by. So tuning in and being empathetic might be harder for them. So what you might want to do is help them. I'm looking at our question at the same time. Catch the cognitions, catch the actions, and maybe borrow your partner's feelings. So I might not be tuned into your feeling, but maybe you can school me and what it's like for you. So if you're my wife and I ask you for sex and it feels like too much to you, try to educate me and why. And maybe for the person on the spectrum, I can get that cognitively, if not affectively.
That's so interesting. I think what happens often, I'm just going to pull back to the, the regular scenario, is that when a woman sort of feels like she's being pestered for sex or being asked for sex, rather than, so here's like probably a perfect casebook case, rather than feeling like she's not translating that into, oh, that's so flattering and that's so lovely that he wants to have sex with me, right? And I'm just really not in the mood right now. What she's translating it into is more like, oh my God, nothing I do is ever good enough.
There's her cognition.
I am exhausted and I can't believe he's not appreciative of all the work I already did today. And all he wants is to give me another project.
There's another, yeah, when will this be over? There's another cognition and the feeling is exhausted.
And the feeling is exhausted.
And then the behavior is to withdraw.
Right.
So if you're sitting with the couple, have her explain that to him. I use the Susan Johnson technique of having them face each other and attune, because there's a lot with eyes. Sometimes I'll say to people.
Sue Johnson for people is EFT, emotionally focused therapy, which is also very similar in terms of getting the emotions at the moment and being able to articulate them for the person. Fair enough? Is that a fair enough?
Yeah. I'm not an expert, but sounds good to me. But having her explain her cognitions to him, and to him, not through me as therapist. Yes. I think so often I just find it with a couple, and I'll often say, talk to each other. I don't need to translate. And have her explain her feelings to him, her cognitions to him, what it brings out in her, and then they can have a really good conversation about that. So and hopefully create an empathic connection.
Right, because they're actually communicating what they're thinking as opposed to what the other person's imagining that they're thinking. So we only have a couple minutes because it's 9:30 and I know the time.
Susan, I hope I hit your question.
I know the time kind of flew, but
that's fun.
Just talk to me a little bit about journaling, because I feel like often when I see patients who have done CBT, this gets back to your homework a little bit. There seems to be a lot of writing.
Well, think about it. I know if ever I take a class or do anything, I'm always taking notes. And I might never look at them, but when I write something down, and I write the entire time I see people, which many therapists don't, because I want to get their cognitions exactly as they say it. If people write things down, it memorializes it and it gives them a chance to look at it. And then they can bring it into the session to be examined.
So do you have your patients coming back in with their written notebooks?
Always. And I actually don't like them to do it on their phones because I think there's something that goes away with it. I prefer them to write it on paper.
Really?
And I don't know what it is. And if somebody wants to do a PhD dissertation on that, I'll share you. But
you have to be sorry you said that, because now you're going to get like this whole host of like.
I've got 5 people I'm sharing right now. That's enough. But
wow.
Yeah.
Okay.
But I think writing something down makes it more alive. And people are able to connect with it, look at it, and give it respect. We need to respect our cognitions because they're there for a reason. And they need to be looked at.
More about that? I feel like say more about that.
Are we getting evicted if we have to stop? We got 5 minutes.
Get evicted. It's me who does the evicting. I just try to be respectful of people's times, but I really think this is so interesting.
I'm not going anywhere. I've been in the house since March. So Where am I going to go? The ocean's there. I'm not going anywhere.
Just spend a minute talking about respecting your cognition.
Yeah. So, I think too often we criticize ourselves for our thoughts. And there's one of the women who's the chair of her dissertation, who's an amazing student. I'm going to give her a shout out. Sam Robinson is asking a really good question. We damn our thoughts. We criticize our thoughts. We try to avoid our thoughts. And I think if we honor what we're thinking, we'll take better care of ourselves.
I totally.
So
totally
if I'm that person who's afraid to be sexual because I think my body doesn't look like somebody in a magazine, and so therefore who would want me? I think there's a part of us that needs to look at the culture that creates a cognition like that and work on some self-empathy.
And then how do you change that thought?
I think by breaking it down and looking at where it came from and offering yourself alternative thoughts. And this is, where cognitive therapy has gotten a bad rap, because some people think I simply say, well, change your thought about that and you'll get better. And now here's where it echoes a lot of psychodynamic theory, where you start to go into the early childhood data and unpack the stories that create your cognitions. Our cognitions don't come out of nowhere.
And then by unpacking the story, it sort of takes the power out of them.
It takes the power out of it, and I think it gives you empathy for yourself. I think all forms of psychotherapy have value, and I think at the core they're about self-love.
Right. No, I totally think that's true. And I think being able to respect the part of your, not to sound now like an internal family system person, which is sort of where I head, but being able to respect those thoughts is really a starting point. It sounds like there was one more question you wanted to address, and then we really.
Yeah, Sam Robinson asks, how do you work with resistance to homework? First thing, not everybody likes the word homework.
Repeat that question slowly. How do you work with clients who are resistant to doing their homework? And I think a lot of people watching are going to say, how do you work with 10-year-olds who are resistant to doing their homework?
Well, that's a whole other story. But for one, if people don't like the word homework, call it therapy exercises. Not everybody's had good experiences.
I like that. Therapy exercises.
Yeah.
I love that.
And what I often do is tell people you'll get more of a quality product if you do homework.
Right.
And homework doesn't have to be a big deal. It could be 10 minutes of challenging yourself next week. Not everybody likes to write. Meet them where they are and let them do what they can do without shame.
Right. Do you find that you have a lot of clients who come in having not done any work in their home outside?
Sometimes, but they're working in their own heads. What I find is that they start out strong with homework and they transition away from it because they're doing the cognitive therapy on their own. Cognitive therapy is very bad for business because it teaches you to be your own therapist.
But the good therapies do that. I feel like that's true about family systems also. Like you end up spending your week thinking to yourself, oh, this is a part of me that's saying this, and this is the part of me that's saying this, and exactly the same way.
It's a very similar model. So look, you're getting into the intrapsychic, so it's going to bring it all the same way.
But I feel like that's what we should all be doing, David. Like we should be teaching our clients how to live their lives, right? Without us. Like that is really the goal.
I think so.
As lovely as we all are, I think that really is the goal.
Look, the goal is for them not to need us.
Exactly.
But to know that we're always there as a safe object in case they want to return.
It's in case there's a pandemic and they need to reach out.
It's gotten busier.
I think we have to get off. So if people
that went fast.
I know. I told you. Remember when I called you? I said a half hour goes really fast, and this has actually been closer to 40 minutes.
But we hang well, so.
We do. We got to do this again. So where do people find you if they want to follow you in social media?
You can go to, I actually don't have any personal or professional social media. I only have private, and if they're on here, they're already following me. Or you can go to my website. No, but
that's not true, because they could be following me and they could follow you because they're like, oh, we want to meet Dr.
One of my friends just posted something great. Paul, who will be getting his PhD next year.
Congratulations, Paul.
He just said plan of action. Some clients really like that terminology, and I do too.
To have a plan of action.
Yeah. So.
Great. Okay. Well,
so work at drdavidw.com.
drdavidw.com. Right. That's exactly a great website. And the Boca Raton Center for Psychotherapy. That's where you are. If anybody wants to harass you and come become a client and do a lot of homework.
A little bit.
Have a great night, David.
Be well. Happy New Year. Healthy New Year. Good yontif.
You too. Thank you. And enjoy your grandchildren. And we got to do this again sometime.
Okay. Are you staying on with me for a minute, or are you shutting us off?
I am.
Okay.